Hello, and thanks for joining us. My name is Thomasine Heitkamp. I'm the co-director of the Mountain Plains Mental Health Technology Transfer Center. I'm pleased to be here this morning in a studio in Grand Forks, North Dakota, to interview Dr. Don Wern on behalf of the Mental Health Technology Transfer Center in Region 8, Mountain Plains Mental Health Technology Transfer Center. And our center is funded by the Substance Abuse and Mental Health Services Administration to assist providers in 6 states in the United States. And the states we serve are Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. And we're here today to interview Dr. Don Wern about adverse childhood experiences and the relationship to mental health disorders. He has extensive experience in writing and advising on American Indian health policy in rural areas, and has served as a leader with both the Centers for Disease Control and Prevention, as well as the United States Department of Health and Human Services. Dr. Wern really is a national treasure in his expertise that he has provided throughout the nation. He's currently, and we're thrilled to have him at the University of North Dakota, the director of the Masters of Public Health program, and also the School of Medicine and Health Sciences, director of Indians into Medicine, and Dean of Diversity, Equity, and Inclusion. We can't give Dr. Wern enough work at the University of North Dakota. So today we're really here to talk about the work that he has done, the research that he's done, the training that he has done on adverse childhood experiences. So welcome, Don Wern. It's great to have your perspective and your knowledge with us today. And well, let's just get started and take a dive into this and talk a little bit about adverse childhood experiences.
Sounds good.
So what is it? What is adverse childhood experiences? Can you give us some background?
Sure. Well, just as the name implies, adverse childhood experiences are adverse experiences during childhood, so prior to the age of 18. And there was a fairly extensive study done in the 1990s in California with the Kaiser Permanente population group. So Kaiser Permanente in California is a very large HMO, or health maintenance organization. So they had charts of many thousands of patients, and they developed a 10-question survey looking at different types of adversity during childhood. So they looked at different measures of abuse, different measures of neglect, as well as measures of household dysfunction. Mm-hmm. And as a result of the 10-question survey, they developed an ACE score, Adverse Childhood Experiences score of 0 to 10. And then they basically correlated the ACE score with various health outcomes that were in the electronic health record. Mm-hmm. So one of the advantages they had in their particular study is that they had long-standing medical records that they could then associate correlations to adverse childhood experiences. And the outcomes were just groundbreaking. Not surprisingly, they saw higher rates of depression, anxiety, post-traumatic stress, certainly addiction, suicidality, correlating with the ACE score, again of 0 to 10. But what they also found that they didn't necessarily expect to find on the front end was higher rates of diabetes, higher rates of heart disease, higher rates of cancer. So we saw very strong correlations between adversity in childhood and poor health outcomes across the board. Mm-hmm. And certainly the mental health outcomes are quite dramatic.
Mm-hmm. Mm-hmm. So how common are we seeing high scores in adverse childhood experience?
Well, each population is different. So I was co-principal investigator of what's called the South Dakota Health Survey. And we conducted this survey around 2014, 2015. And in our population, what we found was that across the board in South Dakota, for the non-American Indian population, at least 50% of the population had an ACE score of at least 1, so had experienced some form of adversity during childhood. For the American Indian population, it was over 80% who had at least an ACE score of 1. So we do see differences across populations, and we do see some correlations between poverty and other adverse social circumstances in a community that then facilitate more adversity in childhood. So it makes a lot of sense. If we have poverty and marginalization and discrimination within a particular population, that will have an impact on the children as well. So it's hard to say that there's one average ACE score because each population is so different. But when we look at it in an aggregated way, pooling together multiple populations, it's at least 60% of the population has at least one adverse childhood experience. And again, those categories include abuse, which would be physical abuse, sexual abuse, emotional abuse, neglect, which is physical or emotional neglect. So those are 5 ACEs. And then there's 5 categories of household dysfunction. And that includes things like mother being treated violently, household member in prison, substance abuse in the home, mental health issues in the home, or an incarcerated family member. And we have some people who have ACE scores of 10 who've experienced all of those things. And not surprisingly, we see very poor health outcomes in people with very high ACE scores.
Thank you. You mentioned violence in the home, and you mentioned domestic violence and sexual assault. Can you talk a little bit about gender and what you see in ACE scores in relationship to gender?
Yes, and most of the studies that we see where we do compare genders, women tend to have higher ACE scores. So as they're girls, they unfortunately experience a little bit more adversity than the boys do, at least in the self-reported data that we can collect. One caveat that I would put forth, though, is that although we see trends, we can't assume that all women have an ACE score and all men do not. You know, that we can't look at aggregated population data and make assumptions about any individual. So it's important to assess each individual. But we do see trends, and unfortunately for young women and girls, we tend to see higher rates of adversity during childhood.
I'm thinking, as you're talking about ACE scores and high ACE scores, it's the very populations that don't have access to supports in their community.
Yeah, we unfortunately, in public health in this country, we tend to see better access to public health and social services in the populations who need them the least. And the populations with the greatest need for public health and social services have less access. So it really is rich getting richer, poor getting poorer, but in this case not financially, very much directly in terms of health. Good health in a community tends to facilitate more good health and more resources. Bad health and poor social circumstances in a community tend to feed on itself and make more intergenerational challenge when we look at adversity. And we had mentioned even looking at violence, and we see higher rates of violence that are associated with poverty. Some of the preliminary data show us that children who witness violence, particularly against their mother, tend to have just as much risk for poor health outcomes as children who suffered violence directly. So think about that. If a child sees violence, that is just as damaging to the future health of that individual as being a victim of violence directly. And I find that really remarkable. And it is a statement that really advocates for more social services programming and recognizing that if adversity during childhood correlates with things like diabetes and heart disease and cancer, then in truth, chronic disease prevention is also domestic violence prevention. And we can draw those lines very directly by understanding adversity during childhood. And I think one of our challenges in our current health system is that we tend to put things in silos. We think of domestic violence prevention as a social service program that's over here, and the medical community is over here. We need to break down those silos because we see very direct connectivity between that type of adversity in childhood and subsequent chronic disease as adults.
Yes. I'm thinking about the lecture that we provided to the second-year medical students on domestic violence and adverse childhood experiences, and your comment that when they work with a patient, that they understand all that background that the patient is bringing. And talk a little bit about that. I was struck by that.
When I was in medical school back in the 1990s, we did not do a very good job of connecting the dots between social circumstances and real life, real world circumstances that our people live in and medical science. In my training, medical science was really treated as its own silo once again. And we would look at the human body as a machine, and we would look at data based on pathophysiology without recognizing that there's a social circumstance in which that individual lives. And we cannot assume that everyone is at the same starting point. So even in very basic terms, if we have a patient with diabetes, we can follow American Diabetes Association recommendations for diet. But not everyone has access to those resources to afford healthy foods. So in a very basic way, if we don't understand social circumstances, we are not going to be effective healers. And I'm hoping as we evolve through medical education, we do a better job of understanding that human beings are not isolated laboratories. We actually live in a social circumstance. And I would like to see improvements in the way we assess social determinants of health, particularly in the primary care setting. And if we just assume that our patients are at the same starting point in terms of the types of interventions we prescribe as doctors, we're making a huge mistake, because there could be social circumstances that limit a person's ability to adhere to our recommendations. And historically what we've done is blame the patient, non-compliant patient, as opposed to recognizing that our system just has done an inadequate job of addressing those types of circumstances.
And we're hoping that all of our schools of medicine in Region 8 are providing this kind of information to primary care providers and our advanced practice nurses, because I think it was and is a very powerful message to our future healers. In Region 8, we have 33 tribal communities. We have predominantly rural areas, remote areas that we serve with very little workforce. Can you talk a little bit about training workforce as we work with mental health providers on this topic, Dr. Warren?
Yeah, when we look at our region, certainly here in the Dakotas, but the rest of Region 8 as well, we do have a lot of rural populations, and in addition we have a lot of tribal populations that tend to be rural as well. And one of the things that we observe is that we have health professions shortage areas throughout the region. So when we think about shortages of primary care doctors, it's throughout the entire region. And what's interesting, in the state of North Dakota, the only areas that really are not health profession shortage areas are the 4 cities. If we look at Grand Forks, Minot, Fargo, and Bismarck, we tend to have providers there, but anywhere else in the state, it's a shortage area. And that's true for primary care, it's true for oral health, it's true for mental health. And one of our big challenges is that we don't have an adequate workforce to meet all of the needs of our populations. So we're doing different types of efforts to promote training of individuals who are from these communities, who are more than likely to go back to the communities and work. So we have programs like InMed, the Indians into Medicine program. We also have for our medical students what's called ROAM. It's a Rural Opportunities in Medical Education. We have the Center for Rural Health, and we're attempting different ways to try to increase the workforce in these regions, with the understanding that we need to do more, that we're not yet at the point where we've overcome the deficits or the disparities in access to services and access to providers. So when we look at best practices, many of the best practices in addressing these issues are generated out of cities. Los Angeles is doing a certain type of program, or they're doing something in Boston or Atlanta, and those are considered evidence-based practices. And my question is always, whose evidence is it? If something's working effectively in Los Angeles, does that mean it's going to work effectively in Watford City? We don't know that. And we need to, in addition to building our base of providers across the healthcare continuum, we need to study these things, look at the outcomes, and develop our own evidence base for what works for us in Region 8, and with a particular emphasis on rural and tribal populations.
And the challenge to us as academic educators is to prepare that workforce, encourage that workforce to engage in shortage areas with Indians into Medicine and ROAM and some of these programs. And also, I think the challenge is to think about telemental health and telehealth. Can you talk a little bit about that?
Yeah, there's some very good studies that show the effectiveness of telepsychiatry, telemental health programming. And I think when we first started implementing these programs and studying them, I think there was a lot of assumption that these are not going to work. People need to be face-to-face and talking. And what's interesting, when we look at some of the qualitative data, looking at patient perspectives, not just the endpoints in terms of disease, but how they feel about that interaction, many people actually feel more comfortable looking at someone on a screen than they do face-to-face. They feel a little bit more at ease to share personal information because they don't feel like they're right next to somebody, which I found really interesting. In addition, particularly for younger populations, they are accustomed to screen time. You know, that's less of a barrier, and they're accustomed to having televideo conferences or even on their smartphones talking by video. So I think that as we move forward, it really is going to be vitally important as a health system and as health educators that we engage technology, because it's going to be much easier to have a centrally located mental health provider that can reach patients across the entire region in one day, as opposed to expecting the patients to either travel hundreds of miles or the provider to see one or two patients at a time during a day, just because of travel considerations. So I really have a lot of faith in the future of technology. It's not going to solve everything, but it certainly is a step in the right direction to promote access to services.
As a technology transfer center, we certainly encourage, an understanding of culture and gender and race and rurality when we're doing this work in terms of understanding capacity to serve. Can you talk a little bit about physical health and its relationship to adverse childhood experience? You touched on diabetes. Can you expand a little more?
Yeah, so not surprisingly, when we see a lot of adversity in childhood, we see strong correlations to mental health outcomes. So we do see higher rates of depression, anxiety, substance abuse, addiction, as well as suicidality. And that's really not surprising when we think about all of the emotional strife that occurs with adversity in childhood. One of the things that I think surprised a lot of the research teams is that not only are there mental health risk factors associated with ACE scores, there's also physical health adversity or physical health poor outcomes. So we see strong correlations between high ACE scores and diabetes, high ACE scores and heart disease, and high ACE scores in certain types of cancer. In addition, there's other measures that are risk factors for poor health outcomes. So we tend to see higher rates of smoking, which puts us at higher risk for heart disease and cancer. We also see higher rates of dropout from school. Again, not surprisingly, when a child has suffered through significant adversity, it has an impact on their cognitive development. It has an impact on their emotional and social development. So the outcomes from ACEs are holistic and they're encompassing. So we certainly see the mental health outcomes that are not surprising, but we see a holistic and comprehensive poor outcome from adversity during childhood. So we even see higher risk factors, even higher risk for victimization. Women who have higher ACE scores tend to have higher rates of being victims of sexual assault and other types of violence as well. So when I look upstream, and I think what are some common causes of our health challenges in this country and some of the root causes for health disparities, going upstream, it's adversity during childhood. If we can eliminate childhood adversity, that population would then have lower rates of chronic disease, lower rates of victimization, and we would see better health outcomes.
Many of our providers, as we look at needs in Region 8, those states that we serve, are talking about wanting to understand trauma-informed care better. Can you talk about trauma-informed care and its relationship to ACE?
Absolutely. So trauma-informed care has been a movement in medical care and in behavioral health care for quite a long time now, recognizing that the clients that we see quite often have unresolved trauma, whether it's adverse childhood experiences or even during early adulthood, we still see adversity. And when people are victims of trauma, whether it's abuse or neglect or other types of dysfunction, quite often there's a certain type of physiological response. And they might be less apt to open up and share experiences. They might have a fight or flight response that's triggered. And for those who don't know what that is, when we experience a stressor, by nature, our adrenaline goes up, our stress hormones go up, because the idea is that we need to prepare the body to either run away or to fight, if we're facing an adversity or a challenge. The difficulty in modern times is quite often we have that fight or flight response physiologically, where our stress hormones increase, our blood sugar increases, our blood pressure increases, but then we don't have the physical exertion associated with that. So people are in this constant state of high levels of stress. And that has a direct impact on health behavior, it has a direct impact on how we communicate, and a direct impact on how we respond to certain circumstances. So if we just, again, assume that every patient is coming from the same starting place, we're making a big mistake. And if someone has a great deal of unresolved trauma, that's going to have an impact on whether or not they fully comply with our medical recommendations. And again, historically, the response was to blame the patient. Non-compliant patient, it's their fault. But in truth, our system has not met people where they are. And if they're in a place that is dealing with unresolved trauma, we need to do a better job of communicating with them. So there's been an entire movement on trauma-informed care, recognizing that we have to have better strategies to engage patients who have unresolved trauma. But I would love to see trauma-informed care extend beyond medicine. We need trauma-informed public health. We need trauma-informed education. We need trauma-informed policing. We need trauma-informed social services. Because when we look at the high levels of trauma in our populations, again, more than half the population has at least one ACE, one adverse childhood experience. That's much higher than, for example, the rates of blood-borne illnesses. But we do universal precautions every time we draw blood, every time we give a shot, but we don't have universal precautions for unresolved trauma, and that's a mistake. And I'm hoping as educators that we resolve that problem, because that's on us. If we're not teaching these vitally important components of engaging patients, then we're not really teaching our students to become the best healers that they can be.
One of the things that you bring that's so powerful, Dr. Warren, is this understanding of historical trauma. So I'd like to have you talk a little bit about historical trauma and the research that you've been doing and how you're able to describe this in a way that people will understand it.
When we think about different types of trauma, I think when we conceive of the idea of adverse childhood experiences, people can understand that, they can grasp that and recognize that if I went through terrible experiences as a child, it's going to have a long-lasting impact on me. What I think a lot of people haven't yet fully understood is that trauma can be passed from one generation to the next. And what we observe in populations that have had significant cataclysmic events, the subsequent generations tend to have worse health outcomes. So some of the very good research has come out of Holocaust survivors from World War II. And when you look at the descendants of Holocaust survivors, they tend to have worse health status than equally matched Jewish populations from Europe who are not descendants of Holocaust survivors. So there's something that happens within those families when we see significant adversity and trauma that somehow gets passed on from one generation to the next. And we haven't proven exactly what happens, but we do see some preliminary indications. There's an entire growing field of epigenetics, and what epigenetics is the study of external forces on DNA. And we have proven that toxic stress can actually change DNA expression. There are things that happens to our own genetics when we're encountering toxic stress, and those things can be passed from one generation to the next. There's been some very good mouse models. It's kind of interesting research. You have to stress out the mice. I'm not sure exactly how they do that. But mice that are under great deals of stress, they can actually measure the changes in their DNA. And those DNA changes are passed on to the offspring. So is it possible that intergenerational trauma could even be mediated through a person's genetics? That certainly is possible. Now, we haven't proven that link, but I believe that epigenetics will provide the scientific platform to better understand historical trauma and how is it that what happened to my ancestors has an impact on me today. Mm-hmm. And when I think about these things, even from a cultural perspective, it makes a lot of sense. We understand that we are direct connectivities to our ancestry, and we are direct connectivities to future generations. Mm-hmm. And the whole spirituality of our DNA really is embedded within all of us, and that deep-rooted connectivity to previous generations. So their experiences and the alterations potentially to their DNA, of course that could be passed from one generation to the next. Mm-hmm. So that's an exciting area of research from a cognitive and academic perspective, but it's even more important when I think about this from trying to understand the need for all healthcare providers to be more cognizant of social and historical circumstances of the patients that we're dealing with. Again, if we look at each patient simply as a machine and don't put into the context of social determinants of health, then we're never going to be as effective as we could be or should be.
Part of that anatomy is those social experiences. And can trauma be in communities?
Absolutely, yeah. So we see toxic stress in a lot of populations. And I think when we see unresolved trauma, it tends to facilitate more trauma. And do abused children eventually become parents? Well, of course. And can they, based on what they've learned about parenting, wind up also abusing their children? We tend to see that run in families. So not only is there potentially a genetic connectivity for trauma, it's also learned behaviors. And unfortunately, in this country, we still have racism, we still have discrimination, we still have marginalization, and in recent years I've seen a lot of that get worse in some populations, unfortunately. So part of what we need to do as healing systems and as educators in the healing arts is to recognize that our social circumstances and the adversity in which populations exist has a direct impact on health outcomes. And when we recognize that there can be toxic stress and trauma within an entire community, that's going to have an impact on the health status of our patients, but even their ability to comply with our recommendations from a medical perspective. So we have to do a better job of understanding these social dynamics if we're going to be good healers.
And because you have this expertise, you've inherited a host of titles at the University of North Dakota and the work that you're doing at the School of Medicine and Health Sciences. But there aren't enough of you. There aren't enough people doing what you're doing, Dr. Warren, in terms of educating people about this big 360 view of trauma, adverse childhood experiences, how we look at patients, how we look at clients, how we work interprofessionally to advance better care with a better understanding of the root cause. So the challenge for us as we work on grants like this is how do we move the needle? How do we expand a greater understanding of diversity and inclusion? And your role as Associate Dean, so, and the work that the Indians into Medicine, that's been around for many, many years.
Yeah, so InMed, or Indians into Medicine, started in 1973. So we're getting close to our 50-year anniversary, actually. 2023 will be 50 years of InMed. We've now graduated 237 American Indian physicians out of that program. So worldwide, it's actually the most effective indigenous medical training program that we've ever had. But it could do even more, and that's what we're trying to do is build upon the existing success that we've had to date. In terms of other perspectives on diversity and inclusion, we need to look at this across the board and recognize that if our mission as an institution of higher education is to improve outcomes for the entire population, diversity has to be a part of that equation. And again, another cultural difference in perspective that I have witnessed is that there is pushback against things like affirmative action or diversity programs. And from that perspective, there's the thought that, well, as an individual, if I have a high enough test score, I should get into a particular program independent of race or ethnicity. And I understand that from an individualistic perspective. But if we look at this from a population perspective, and if the role of the university is to address its region's societal and social needs, diversity is a part of that equation because we see people from diverse populations tend to work in diverse populations. American Indians work in tribal populations at a much higher percentage than non-Indians. That's understandable. So is the purpose of a university to educate individuals, or is it to meet the needs of society? And from my perspective, it's to meet the needs of society. And part of that, educating the individuals, is a means to that end. It's not the end within itself. And I think that's our challenge in these types of efforts, is ensuring that our programming is not intended to eliminate anyone. It's trying to be as inclusive as possible. And we also need to build out our ideas of inclusion and diversity. That, of course, here in the Dakotas, of course, Dakota is a tribe, right? So we recognize we have a significant number of American Indian people who live in this region. But we have other types of diversity, even coming from a rural population, coming from poverty, no matter what your race or ethnicity is part of diversity.
One of the things that we oftentimes hear from providers is We educate them on adverse childhood experiences. We talk about social disparities of health, poverty, all the issues we've been talking about this morning. But they want tools on how to do better work to address this concern. I don't see any doubt that this is an issue and the science is there to create this concern, but how do we, as people who educate providers, as teach evidence-based practices to providers, discuss next steps to address some of this? What's your thoughts on that?
I think there are some very good tools and resources we could be using in the primary care setting, for example. So there are some validated survey instruments and assessments for social determinants of health. And I think that we would do a much better job in the primary care setting if we understood the social circumstances in which our patients are living. So throughout Canada, they do assessments of social determinants of health, even in the primary care setting. And just recently, I was very pleased to see the American Academy of Family Physicians has adopted recommendations for tools to assess social determinants of health. So I think a number of things that could be done. One would be to look at social determinants of health in the primary care setting, but we also could consider looking at ACE scores in the primary care setting and in other, whether it's mental health or other types of circumstances, because adversity in childhood has such a far-reaching and sweeping impact. The challenge with assessing ACE scores is that for children, who's going to answer those questions, right? So if it's a child going through adversity, you ask the parents or the caregivers. And unfortunately, in many circumstances, it's the parents or caregivers that are causing the adversity, right? So assessing it in the pediatric population is much more complex than you would initially think. So we have to be very careful about that and how we assess those things. The other component, even if we're doing research and asking adults to recollect what their adversity was during childhood, that can be triggering for a negative emotional response. So we have to be sure that if we're going to ask these questions, that we have resources and services available to address any potential negative emotional outcomes. So just sweeping questions about ACE scores across the board has to be done very, very carefully. And we have to think about the context in which we're asking those questions, even the clinic setting. But aside from looking at ACE scores, there are very good assessments for social determinants of health, and I think that's a step in the right direction.
What the American Academy of Pediatrics is doing.
Yeah, I believe they are too, but for sure the American Academy of Family Physicians.
Family physicians? Yeah. Yep. Okay. That's good to hear. One of the things that our providers say is, okay, we've got this ACE score. We know it's high. We know it might not just be high for the people we're serving, it might be high for the providers of services as well. So now we need to move forward and we need to understand that. And how do we access the kinds of supports in the region that we're in? And you can find treatment services in Denver. And you mentioned our 4 larger communities. But if you're in Pavilion, Wyoming, and you need supports, that's a little tougher job for these providers.
It really is, and like I had mentioned, in our rural populations, we have such a shortage of health professionals, particularly in mental health and specialty care, but even in primary care. So that might be an opportunity. If we're going to be assessing unresolved trauma, then we do need to have interventions available once we identify it. We shouldn't be screening for things that we can't do anything about.
That's right.
So I think part of the equation is, as we're assessing these numbers, we need to also make sure that we have access to services. And I think there are, like I had mentioned, some really good telemedicine-based psychiatry and other mental health programming that could be employed. In addition to that, there is some really good evidence coming out of the Veterans Administration looking at unresolved trauma and different types of approaches to therapy and cognitive therapy for veterans who've undergone significant trauma. Of course, it's an entirely different population, entirely different type of trauma. But I would venture to say that many of those types of interventions could probably be used in populations with high ACE scores. But we need to make those services available, and we need to study the impact and outcomes.
And that may mean recognizing that stigma exists in accessing treatment.
Unfortunately, that is true. And as part of our South Dakota Health Survey, stigma was a big issue. And one of the factors that limits or inhibits people from pursuing services is stigma associated with it. It's fascinating to me that in our current landscape, if someone has high blood pressure, there's no stigma associated with taking your medication and going to the doctor to take care of your blood pressure. But if it's depression, there is a stigma associated with that. Or if it's addiction, like opioid addiction, for example. Unfortunately, stigma has limited people's pursuit and utilization of services that could save their lives. And that to me is really a tragedy. And just even thinking about things like addiction and how we manage opioid addiction, one of the outcomes of ACEs, so again, the child is innocent. The child, through no fault of their own, could be experiencing significant adversity. We see a lot of self-medication for unresolved trauma. It could be food, it could be promiscuity. We even see higher sexually transmitted disease rates with high ACE scores. And it could be alcohol, it could be other drugs, including opioids. And historically, the way we have managed things like heroin addiction in this country is through incarceration. So think about that from the 30,000-foot level. You have a child who, through no fault of their own, had significant adversity. They are self-medicating, and they very well could have children of their own. Yeah. One of the ACEs is having a family member incarcerated. So when that child is an adult, self-medicating their ACEs, we put them in jail and create an ACE for their children. Mm-hmm. This is not intelligent. This is not smart. This is not ethical. We cannot incarcerate our way out of addiction. We have to be much smarter about this. And again, when we look at sociological circumstances, I'm hoping as we move forward as a healthcare industry and as a healthcare profession, we make smarter decisions on how to address some of these social circumstances.
And really seeing addiction as a disease, like you would see diabetes or hypertension, and taking that stigma away. And I know a big part of your work is doing that. The work that we're doing with our technology transfer centers throughout the country is doing that. And I think it's particularly difficult in some of our rural communities where people are identified as someone seeking treatment. And we really have been doing our part to encourage integrated care, where we do that primary care along with that mental health care and expanding access through one stop.
Yeah, and I think that's vitally important. And I think for our younger generation of current students, recent graduates, I do have hope for the future, and I see more acceptance, maybe through social media, other media, that our younger populations are more connected to other populations, so there's less potential stigma or judgment of other populations. Of course, it's not across the board, but I see trends that are encouraging. And one of the issues that I see, I've talked to provider groups, whether it's rural or reservation-based, and there's reluctance to even embrace things like medication-assisted treatment. So there are medications that can assist in overcoming opioid addiction.
Yes.
But I see providers that are reluctant to prescribe it. And some of the arguments I've heard include, well, if I prescribe this particular medication to help someone overcome opioids, they could be on that medication for a year. And my answer to that is, well, if you start metformin for someone who has diabetes, they're going to be on that medication well more than a year, the rest of their life, So the fact that someone has to take a medication for a long period of time, to me seems like a silly argument against MAT, medication-assisted treatment. I've also heard people say, well, we can't just prescribe the medication, there has to be education and counseling associated with that. It's like, well, yeah, the same is true for your diabetic patients. They need to have education. They have diabetes education, counseling, and other services. So there, even among the provider communities, I see in certain sectors, unfortunately, that sense of stigma around treating addiction. But we should be thinking of addiction as a chronic disease and approaching it the same way.
And I think that's a critical piece to people's level of comfort and, honestly, hope. hope and love. You talked about love. And anything else you'd like to add?
I would just say, but this last comment is that hopefulness should be a measure of health,
Yes.
Because we see very clearly when there is a sense of loss of hope, we tend to have worse outcomes. And it's really fascinating when I think about this, even from a traditional perspective, from a Lakota cultural perspective. We look at things very holistically, not just physical health, but also emotional, spiritual, and mental health. And much of that is rooted in our cultural values, our belief systems, and our attitudes. And when I was in medical school, this was back in the 1990s, and I come from a family with a lot of traditional healers and medicine men. Mm-hmm. And one of my uncles was asking me what they were teaching me at medical school, and I had just learned how to interview a patient. And I was very proud of myself because I memorized the process of interviewing a patient. You know, it's the chief complaint, past medical history, history of present illness, past surgical history, medications, allergies, social history, family history, review of systems, laboratory data, assessment, and plan. So,
well, there's some brain memory.
yeah, so all of these things that we were taught in the line, and I was, kind of proud of myself. I had memorized all that. And what he said is, no, that's all wrong. Yeah. He said, the most important question you can ask a patient, if they have diabetes, for example, the most important question you can ask is, do you believe you can manage this? And that's brilliant, because you could have two people with the same condition. Someone who believes they can manage it is at a completely different starting point than someone who believes they cannot. And I didn't learn that at Stanford Medical School. I learned that in Porcupine, South Dakota from my uncle Rick, who's a medicine man. And I've taken that to heart, in that if we assume everyone's at the same starting point, shame on us as a health system, because a sense of hopefulness and belief in our ability to manage something puts us at a completely different starting point than when we have lost hope. And we have patients who have lost hope, but there's things we can do not only to improve their outcomes, we could save lives if we just ask those simple questions. So I'm hoping as we move forward, we integrate some of the best of what diverse communities can offer the healthcare system with the best of medical science. And that's one way we can try to reduce disparities and improve outcomes for everyone in this region.
Well, Dr. John Warren, that's a very powerful message that I so appreciate you taking time to share with our providers in Region 8 and across the country. As we think more holistically, we engage with love and hope. I really thank you for your time this morning and your expertise. It's been invaluable. Thanks.
I appreciate it.